A very good evening to everyone. On behalf of Indian Pleural Network, I invite and welcome you all to our webinar on pleural infections. Today, we'll be having a presentation on pleural infection by Dr. Richa Gupta, and this will be followed by a panel discussion. As we all know, pleural diseases are very commonly seen by all of us, and despite of all advances which have happened till now, there are still a lot of gaps in the diagnosis and management of pleural diseases, and they are still associated with significant morbidity and mortality. So, with this background, I'd like to introduce all our faculties who are there today. Our speaker is Dr. Richa Gupta, who is professor and head of the Department of Respiratory Medicine at CMC Vellore. Now we have expert panel with us, which includes Dr. Anant Mohan sir, who is professor and head of the Department of Pulmonary Critical Care and Sleep Medicine at AIIMS Delhi. Then we have Dr. Shushmita Roy Chaudhary. She is the director of pulmonology at Fortis Hospital, Kolkata. Then we have Dr. Amit Dave, who is consultant interventional pulmonologist at Daya Madhav Hospital and Sterling Hospital, Vadodara. And last but not the least, our expert surgeon, Dr. Manjunath Bale, who is a consultant robotic and minimal invasive thoracic surgery at Yashoda Hospital, Hyderabad. With this, I invite Dr. Richa Gupta to start her presentation for today on pleural infections. Dr. Richa, please.
Thank you so much, sir, and good evening, everyone. I'm just going to share the presentation and then we start talking. What happened? Right. Can you see the presentation?
Yeah.
All right. Yeah. So I think, oh, I'm so sorry. Something has gone wrong with me. Yeah. With the presence of so much eminent panelists, I think my job is probably done with the panel discussion itself. But since I have been given this job of talking or maybe build up a topic of discussion for the panelists, probably I'll be just taking some 20 minutes to talk about the management of pleural infections. For the interest of our trainees or postgraduates who have joined, would just like to define what is parapneumonic effusion and empyema. So basically, PPEs are associated with bacterial pneumonias, lung abscess, or infected bronchiectasis. Almost around less than half of the bacterial pneumonias may have parapneumonic effusion. As far as empyemas are concerned, generally 60% of the empyemas are parapneumonic and 20% of the empyemas may arise from thoracic surgical process, whereas 20% of them can be because of the various conditions like thoracic trauma, esophageal rupture, and things like that. We know that parapneumonic effusions are of three stages: exudative, fibrinopurulent, and the organizing phase. Now, if we look at this based on the biochemical and the ultrasound characteristics, these stage 1 are very nicely defined. And it says stage 1 is simple exudate, which is also called as uncomplicated parapneumonic effusion, where pH, glucose, LDH are all okay, gram stain is negative, and ultrasound, if you do, there are no loculation and you have a free-flowing fluid. Whereas when the pH is less than 7.2, glucose is less than 40, and LDH is more than 1000, with or without gram stain being positive, and ultrasound shows there is an echogenic effusion. It's not that black anechoic effusion. There may be few floaters or loculations in that. This is called as a stage 2, or also known as complicated parapneumonic effusion or fibrinopurulent stage. And stage 3 is the organizing pneumonia, where you can have the frank pus, or you may have the biochemical parameters as in stage 2, but ultrasound shows that there is significant visceral pleural thickening and plus minus trap lung may be there. So this is how the Parapneumonic effusion is classified into 3 stages. Why it is important? Because the management depends on in what stage your patient is coming to you, and accordingly we have to plan the management. A bit about an epidemiology. Over the last few decades, there has been increase in the incidence of pleural infection, and the shift is there towards more elderly people. The microbiology, if we look at in a systemic review published in 2019, the most common organism reported was Staph aureus. But there is some differentiation based on from where, what is the geographical location of the patient. So in tropical areas, pneumococci is more commonly reported, and in temperate, it is streptococci. Also, we know that the microbiology pattern is different between community-acquired versus hospital-acquired pneumonia. Now, what is all of us as the physician feel is, though we know this is a complicated effusion or even in empymas, the culture yield on the pleural fluid is very less. It is moderate, or the best would be up to 60%. And if we add the nucleic acid amplification test, then it further increases by 10 to 15%, but then the tests are very costly. So with this background, I would just like to present the data from CMC, which is an unpublished data going for publication. 64 patients with empyema or complicated parapneumonic effusion, culture positivity was only in 36% of the patient. Community acquired was 86, hospital acquired were 14%, and the most common gram-positive organism was Streptococcus, negative was Pseudomonas, and anaerobic was. So with this background, I would just try to answer some evidence-based questions for the diagnosis and management of pleural infections. So as I said, what is, patient comes with a parapneumonic effusion or an empyema, you do what would be the best. You start on empiric antibiotics, but if you get the culture positivity, you are very, very happy. But we know that culture positivity is not very good. So what are the ways by which we can increase the bacteriological yield in pleural infections? So study has shown that if you inoculate the pleural fluid into the blood culture bottles, it increases the yield by about 21%, both for anaerobic and aerobic pathogens. Then the audio study from in 2018, again from it says that pleural biopsy had a higher microbiological yield than the pleural fluid or the blood specimen, 45 versus 20% versus 10%. So in this study, in 25% of the patient, the pleural tissue was the only investigation that captured an organism. So I remember when I was doing my postgraduate, if any patient with empyema comes, we used to be told that there is no need to do a pleural biopsy, straight put the chest tube and start off antibiotics. But in suspected bacterial pleural infections, where pleural biopsy may be considered, where there is absence of microbiological evidence and lack of clinical improvement. We look at the diagnosis. There is no second thought about that. Among all the diagnostic imaging modalities, say it's chest X-ray or ultrasound, thoracic ultrasound or CT chest, thoracic ultrasound is more sensitive. It can identify small effusion. Certainly, it is much, much more sensitive than a chest X-ray. It not only establishes the echogenicity of the pleural fluid and helps you in staging what stage the parapneumonic effusion is, but it also identifies the loculations and septations much better than the CT thorax. But do we say that CT thorax doesn't has no role? Certainly not. CT has its own importance, and we will see where do we need to do a CT scan. In a retrospective study of 66 parapneumonic effusion patients, it showed that ultrasound was the best chest imaging modality to rule in the presence of complicated parapneumonic effusion. But pleural ultrasound has the sensitivity and specificity of 69% and 90% respectively, whereas CT chest had 76% and 65% respectively. So does that mean that CT is out? Certainly not. CT thorax may not be required upfront as an initial imaging, but It gives you quite a bit of information, and it should be done when there is a loculated effusion which is not responding to chest drain and antibiotics, to decide on an appropriate chest tube position, or when we are planning a surgical intervention for the patient. Besides that, what are the predictors of complicated pleural effusion on a CT thorax? All of us know the split pleura sign, extrapleural fat enhancement, septations, thickening and enhancement of the parietal pleura, or presence of air foci inside the fluid. So this is something very common I put up when I do ultrasound thing. So you see a chest x-ray where you are seeing an homogeneous opacity, and that's all we can make it out from the chest x-ray. We did a CT scan and we found that CT thorax is showing that there is loculated effusion, but within those loculations, within that loculated effusion, whether we have internal septations, CT does not tell us that, and ultrasound is the better modality to look into the internal septations. Coming to the management, at times the pleural infections treatment becomes complex, especially if the pleural fluid is having septations and loculations. So the treatment wise, the management wise, it is you have to drain the pleural fluid and you have to give appropriate antibiotic regimen. Now, pleural drainage, in what stages we have the risk stratification, and we will see not all parapneumonic effusion may require drainage. Having said that, when the septations and loculations are there, it prevents the complete evacuation, and that is the case where we would like to give other medical management in forms of intrapleural fibrinolytic therapy, or we might do some semi-invasive medical thoracoscopy, or patient needs to be referred to the surgery. Besides, in the management, something which we forget is appropriate nutrition and thromboprophylaxis for this patient. Let's look at one by one quickly. Now, based on the imaging and pleural fluid characteristics, there have been 4 categories which have been put it up forward. This is based on the poor outcome, the risk of poor outcome for the patients. So category 1 is very low risk. So here the effusion is very small. It seems to be free flowing on an ultrasound. So in these cases, no thoracocentesis is indicated, since the risk of poor outcome is very, very low. Category 2 is low risk, where the effusion is small to moderate, and when I say moderate, it is less than half the hemithorax. The fluid will be free flowing. Of course, you do a diagnostic tap, you find that there may be negative culture, and gram stain also will be negative. Now, in these patients also, if the patient, depending on if it is just around 10 mm or 1 centimeter thickness, you may not need to aspirate it. But if it is around half the hemithorax or little more, then probably you would require to remove the fluid, especially patient is having fever, or a patient is symptomatic. Then comes the category 3, where there is moderate risk of having poor outcome, where the fluid is equal to or more than half the hemithorax, and we are seeing loculation. If there is a CT scan, we see the thickened pleura, or the pH is less than 7.2, or positive gram stain. So any one of these character, if it is present, it becomes a moderate risk for poor outcome. And category 4 is the high risk, where the pus is there, frank pus is there, and this certainly 100% needs drainage. So I believe category 3 and category 4 both requires chest drainage, and if they are not responding to the chest drainage and antibiotic therapy, then this may require further intervention in terms of medical thoracoscopy, surgery, or IPFT as indicated. Coming to the risk stratification, we know that BTS guidelines talks about that rapid score can be used to stratify the risk pleural infection according to the increasing risk of mortality into categories. Now, this is actually derived from MIST-1, and it was validated in MIST-2 trial. And the purpose of this score is to identify patients with pleural infection and who are at high risk of death. So you would like to act more aggressively in these group of patients. As far as we say that most of the parapneumonic effusion is associated with pneumonia. However, pneumonia severity scales which we have, they are not valid for estimating the likelihood of developing complicated parapneumonic effusion or empyema. So what is this rapid score? It has these 5 parameters into picture: renal function, age, purulence of pleural fluid, infection setting, and dietary factors. And there are scoring accordingly. Score 0 to 2 is low risk, score 3 to 4 is medium risk, score 5 to 7 is high risk. So certainly medium and high risk, we have to be a little more aggressive. So it is just a risk stratification, rapid score. Coming to the antibiotics. Now, what is the best empirical antibiotic of choice by the time you are waiting for the cultures to come? It should be, we know, wherever there is pus, antibiotic therapy should be initiated empirically at the earliest, depending on what you are suspecting, whether it is nosocomial or it is community acquired. So if it is community acquired, the drug of choice would be amoxiclav in monotherapy, or third generation cephalosporin with clindamycin or metronidazole, or if the patient has penicillin allergy, then respiratory quinolone with a pinch of salt with coverage for anaerobic, or monobactam with metronidazole. And if it is hospital acquired, we know that hospital acquired, there may be significant proportion of resistant gram-negative bacteria, anaerobic and MRSA. So therefore, a coverage should be something which covers the entire spectrum. So you use broad spectrum anti-pseudomonas cephalosporin with metronidazole or clindamycin plus vanco or linezolid, and likewise. What is the adequate duration of antibiotics? So I think we may have a panel discussion, and we will have opinion from our panelist as well. But this is something which is an evidence-free area. What is the duration, appropriate duration of antibiotic therapy in pleural infection? We don't have much of the evidence, so that's why I'm saying it's an evidence-free area. And whatever people are saying that it should be given for this weeks or that weeks is actually extrapolated from the lung abscess treatment. So the total duration of treatment ranges between 2 to 6 weeks. Study from Mayo said that 3 weeks of treatment was adequate to prevent treatment failure. So again, there are no studies comparing various duration of antibiotic strategies, but at our center, we give antibiotics for at least 4 weeks. Coming to the drainage, empyema, if it is frank pus, it always requires drainage. There is no second thought about it. But if it is a non-purulent parapneumonic effusion, then there are certain biochemical criteria, like if pH is less than 7.2, LDH is high or glucose is low, a gram stain is positive, though still it is looking very free-flowing and non-purulent effusion, but gram stain is positive, you have to do a drainage. Or radiologically, if it is more than half hemithorax or loculations or internal septations are there, we need to do a drainage, and that we have discussed in earlier slides as well. Coming to the most, topic where we try to understand what is the role of intrapleural fibrinolytics. So, 2 meta-analysis of RCTs, not missed and 1-2 we are talking about. This said that giving intrapleural fibrinolytics improves fluid drainage and duration of hospital stay, but insufficient evidence to support the routine use of this therapy for all parapneumonic effusion and empyema. So that has to be a selective group. Then come MIST-1 and MIST-2. So MIST-1 and MIST-2, none of these studies demonstrated that fibrinolytics were superior to the placebo, except the combination of TPA and DNS, and we know that, and we were discussing this also. So according to MIST-1 and MIST-2, they say fibrinolytics are as good as placebo, but if a combination of TPA and DNase is given, it is helpful in patients with parapneumonic complicated effusion where the drainage is a problem. Now, this benefit of a combination of TP and DNase has been confirmed by some other studies as well. And in one of the studies, they said that the therapeutic combination prevents surgery in 91% of the cases. And the rate of pleural bleeding was around 3% and it was non-fatal. So there is enough data to say that the combination works. But what about the cost of these drugs in India? So these drugs, what I'm talking about, the TPA or the LT plays, for 20 mg, this is CMC rates I'm talking about, is 25,500, and we need to give 10 milligram BD for 3 days, so that would account to 76,000. DNA is not available, but when I looked at the internet, it is something like 8,000. So 5 milligram BD for 3 days, again 48,000. So it comes to 1,24,000 per patient. But then I'm not sure. I mean, as far as I know, DNase is not available in India. Our esteemed panelist can enlighten us that if I'm wrong on that. So what is Indian experience? I would go to studies. One is a retrospective study by Dr. Berthwal, where 200 patients with loculated pleural collection and failed tube drainage were managed with streptokinase or urokinase. Again, this is a retrospective study, and they found that it was effective in around 61% of the patient, and both STK and UK were similar in terms of their efficacy. The other study comes, which is kind of a comparative study between strepto and urokinase with 28 and 38 patients with loculated diffusion. Again, the criteria was, this was not a randomized control trial, but this was on the physician's discrimination. Some people went into streptokinase group, some people went into urokinase group with loculated diffusion. After they were put in the chest drain, and once the chest drain stopped draining, then a chest x-ray was done, ultrasound was done, and if there was still evidence of loculated collection, then these patients were subjected to either strepto or urokinase. They have a very good clinical response of 80%. And the radiological as well as clinical response were almost similar in both the arms. So these are some data which actually gives you a little a little evidence towards that streptokinase or urokinase does work. And I'm sure all of us around India at one point of time would have used these drugs. Coming to the nutritional aspect, low serum albumin is most of the time seen in these patients because of poor nutrition or chronic infection, and it is one of the predictor of adverse outcome. So it is very essential while we are managing these patients that we should not ignore these aspects. The nutrition should be adequate nutrition support should be given, and also prophylaxis. There is high risk of developing VTE disease. So if there is no contraindication and we know the patient is sustained for more than 3 days, that is a policy at our place, we give prophylaxis with low molecular weight heparin. But at the same time, it's not just the policy I'm talking about. This is also being advised by some of the guidelines. Coming to medical thoracoscopy, what is the role of medical thoracoscopy in empymas and parapneumonic effusion? So there are retrospective studies of patients ranging from 40 to 127, and they have said that there is a very, very good response, a success rate of around 91%, and that seems to be pretty good. The surgeons may not agree. The prospective study comes from neighboring country Pakistan, where 160 patients with multiloculated empyema were included. MT was done, and around 94% patients of stage 2 empyema had a successful drainage done, though around 5.6% patient developed air leak, and one of them died as well. They concluded that it's an efficient and cost-effective intervention, particularly in resource constrained settings. Again, there is another prospective study where gram pus. So here, loculation was not a criteria. The criteria was whether frank pus or gram stain positive patient with sepsis is there. 30 patient, 19 had free flowing empyema, and 11 had multiloculated empyema. MT was successful in 26 out of 30 patient. 4 patients required surgery, and etiology, they were able to see in 23 patient malignancy and 6% patient tuberculosis. So they did said that, it is an minimally invasive effective modality in the management of empyema. If you look at the systemic review and meta-analysis for medical thoracoscopy treatment for pleural infections, I would say that, we had this different studies. We have the success rate ranging from 75% to 94%, and it was like in some of the studies have considered successful intervention if there was no surgical intervention, and some of the studies has looked into the radiological resolution. So pool treatment success rate is about 85%. Pool complication rate was around 9%, and an additional 9% was found if post-thoracoscopy, intrapleural therapy was given. So additional over the medical thoracoscopy success, there were treatment success. If you add intrapleural fibrinolytic therapy, you have an additional 9% advantage. If we talk about the guidelines, none of the guidelines talk about, they do not mention medical thoracoscopy as the line of treatment for these empyemas. 2 or 3 more slides. So we know intrapleural fibrinolytic therapy, in our country at least, we have experience is good. We also feel many of us must be doing early medical thoracoscopies. There was a randomized control trial where they looked in between the two, which is better, and they found that total length of hospital stay was less in medical thoracoscopy. The median length of stay after an intervention was also less in medical thoracoscopy. But when we considered in terms of adverse event, mortality, or treatment failure between the two groups, or any serious complication, there was no difference. But certainly there was a difference in terms of total length of hospital stay in both the groups. Role of MT in pleural infection, we know those who are doing it, removes adhesions, breaks septations, helps in draining the fluid, enhances the drainage. It is done by the pulmonologist under conscious sedation, less cost, and of course reduce the hospital stay. But having said that, it should be done only at the centers who are equipped and trained to do these procedure. One thing, there should be a backup of the thoracic surgeon as well. So in stage 2 empyemas, medical thoracoscopy is superior to ICT, intercostal tube and drainage with or without fibrinolytics. But in stage 3 empyema, in some of the studies, MT has shown to prevent the need for surgical intervention in around half of the patients. But if you are doing it, it should be offered early in course wherever it is available. When to refer the patient for the surgery, this is the last and only slide. The presence of flocculation rather than the prevalence of the fluid may be related to the failure of treatment. So surgery is required when the medical treatment fails, when there is highly organized empyema with marked pleural fibrosis, or stage 3 empyema, straightforward we should give it. Although it is estimated that the percentage of patients with pleural infection who may require surgery is around 20 to 30% only, provided medical management and drainage is done well in time and appropriate antibiotics are given. But the practice is highly variable, wherein at some places the surgeons want to operate the patient early disease. But as a physician, we know there are lots and lots of lots of I would say problems with that. Many times the patient is not willing to undergo a surgery. Many a times patient is not fit to undergo a surgery, and sometimes many a times, actually not sometimes, we don't have the good thoracic surgeons to help us out in these kind of patients. So concluding, incidence is increasing. Key aspect is managing early diagnosing, initiation of antibiotics, and draining the fluid. Ultrasound plays a vital role IPT, as I said, is beneficial in stage 2 or 3 empyema. Medical thoracoscopy may be an early treatment option with potential diagnostic as well as therapeutic benefit. And combining all of these may actually lead to few surgical interventions. So that is all from my side. I think, yeah, thank you so much.
Thank you, Dr. Richa Gupta. It was really a very enlightening presentation on pleural infections. Now, as the next part of this webinar, we're starting a panel discussion. We have 4 eminent panelists with us, and we start with the panel discussion with Dr. Anant Mohan sir. Dr. Anant Mohan, how has the epidemiology of pleural infections, particularly empyema, evolved in recent years? And are we seeing changes in the causative organisms or the patient's demography? What's your take on it?
Yeah, thank you. As already has been mentioned, pleural infections are common, and in fact, in the last couple of years, there is some evidence to say that they have become more common. And this is obviously from the Western literature, not exactly from our local literature. But yes, again, in the last 2 decades, there have been some changes both in the demographics as well as the microbiological epidemiology of this condition. Basically, what has happened is that traditionally it used to be the empymas and infective pleural effusions were mostly caused by the streptococcus species and streptococcus viridans, and including streptococcus pneumoniae. Now that is changing, and now especially in many pockets on the western side, it is the staph aureus which is becoming more common. In fact, some papers in fact go on to say that it is actually the commonest in their entire country. So that is happening. So there is a trend towards that. Also, anaerobic infections are also an important part of these empymas. Again, about 15 to 25% of all infected pleural effusions may be anaerobic or part of a polymicrobial infection. The reasons for this we'll talk about. So these are the changing epidemiology, and in staph, MRSA also is becoming more and more important, especially in the ICU setup. So that is another something that is happening. As far as the epidemiology is concerned, the patient profile, traditionally empyema used to be a disease of the younger people, but now again the trend of the is now that it is more commonly seen in the older age group, maybe because of the changing demographics, older lifespan, etc. And also because of associated comorbidity which are happening, urbanization, more of diabetes, more of renal failures, more of immunosuppression, more of cancers. All these are risk factors for the development of pleural infections or empymas. More of ICU stay, more of ventilator patients aspirating, leading to anaerobic infections. So all these changes in the medical management, demographics, etc., are leading to changes in the overall epidemiology of the empymas and pleural infections.
Thank you, Dr. Anand Mohan sir. That's a great insight about what is the current trend in the epidemiology of pleural infections. Now I move on to Dr. Sushmita. Dr. Sushmita, what's the role and limitations of pleural fluid analysis, that is, include the pH, the glucose, LDH, cell counts, microbiology, etc., in guiding the initial management decisions? How do you investigate these patients in the form of pleural fluid analysis? How do you do the workup? And what is its role and what are its limitations? Dr. Sushmita, please.
Thank you. Thank you for the question. I think all of us who work in pulmonology and deal with pleural effusions know that there are certain things that you look at, whether it's an exudate or a transudate. And for that, you do basic tests in the pleural fluid analysis of protein, LDH, ADA. So these are helpful when you are looking at what is not frank pus, or what you call it as thin pus. So over there, the value of, pH, the value of LDH, and the value of ADA and protein comes in. If it's frank pus, then you probably don't want to do pH or protein. So there you know exactly that this is pus we are dealing with, and we don't want to know whether it's an exudate or not. As far as ADA is concerned, ADA doesn't really tell you what is the source of infection. ADA can be raised in any kind of empyema where the lymphocyte count is really high. So therefore, very high ADA counts are found in empyema, and they're not suggestive of tuberculosis in any way at all if it is pleural infection or frank pus that we are dealing with. But microbiology is what really helps. As Richa showed in her slides, that only about 36% of cases you will actually find culture positive. But definitely microbiology helps in finding out not just in gram stain but initial fungal stain also, and culture can help. But basically the limitations are when you are dealing with things like glucose. So these have to reach the lab fast, because in empyema glucose levels are as it is low, and the longer it takes for your sample to reach the lab, the lesser the chances of a true depiction of the value that you get out of it is going to be. So I think these are things that we look at. LDH definitely is very high. If you have thin pus and LDH is very high and the total count is very high, it points towards it being pus, especially in thin pus.
Okay. Any limitations you would like to discuss?
So just as I just said, limitations are that number one, glucose levels. Number two is culture negative doesn't really mean there is no infection, because only in 36% of cases you're actually going to find a positive report.
Okay. Thank you. Now we move on to Dr. Manjunath. Dr. Manjunath, from a surgeon's perspective, are there specific patient populations or types of pleural infections that you are seeing more frequently in your practice? What's your experience on it?
Sir, as Anand Mohan sir said, empymas are generally patients who are younger patients. I agree to it. Now, what we have seen is recently there are younger patients who are developing diabetes and who are having a sedentary lifestyle are more prone to having pneumonic effusions, and they are more prone to have these empymas. And this is you can say a new trend. Also, we have older patients with CKD, CLD developing empymas more frequently than earlier because they are living longer on dialysis. They are living longer with management of CLDA. So they are coming up with fresh set of complications like empyema. I think the spectrum of tuberculosis still remains the same, sir. We are seeing the same kinds of patients. Be careful while walking down the ramp, as it is wet due to the current weather. Same kind of patients are seen in tuberculosis, sir. Only thing is the newer, younger patients with empyema are younger patients with diabetes and immunocompromised conditions.
So you are seeing more and more patients who are younger and more comorbidities. That's what you want to tell?
Yes, sir.
Yeah. Okay. Thank you. Now moving on to our next question with Dr. Amit Dave. Dr. Amit, what's the role of thoracic ultrasound in the diagnosis and management of pleural infections, and how does it helps you in decision making and management of these patients?
Thank you, sir, for first of all starting this initiative. It's wonderful actually to discuss particularly organ. And regarding your question, already Richa ma'am has mentioned that ultrasound is most important tool. Even I would say it's the most important arsenal in your practice nowadays, because ultrasound can guide you even before you diagnosis for a go for tapping or biochemical analysis. There are parapneumonic effusion can be diagnosed on ultrasound on the basis of echogenicity and anechoic. We can divide them. Firmly echogenic effusion, it may be a parapneumonic or exudative effusion, and anechoic free flow fluid can be a transudative bilateral effusion. So ultrasound can guide you not only in predicting the biochemical, also in intervention, that whether you have to tap it or not. As Richa ma'am has mentioned already in her lecture, that category 1 free flow effusion or small effusion, you can avoid doing a thoracosynthesis. Similarly, if you see on ultrasound multiloculated effusion or a multilocular thickenation, straight away you can go for a tube thoracotomy. So ultrasound is the most important tool in a diagnosing, especially concern to the pleural effusion category. As far as concerned with infection, so infection, pleural infection, the most important is that echogenicity of that particular and septations before tapping of the pleural effusion. Few signs are unheard signs. I would say that suspended microbubble sign, and although can guide you that it is a empyema, but it requires a good training in ultrasound itself. Decision making is, I would suggest that it based on typically how well versed the operator of ultrasound while doing the ultrasound
I
of
think,
pleural effusion.
thank you, Dr. Amit. That's really wonderful explanation. Yes, ultrasound helps a lot in seeing adhesions, septations, pleural thickening, and the echogenicity of the effusion that may guide us the further management. Now, the next question is to Dr. Anant Mohan, sir. What is your initial medical management strategy for a suspected pleural infection even before definitive diagnosis? And what do you consider, when do you consider starting antibiotics, and what are your empirical choices? Dr. Anant Mohan, sir.
Yeah, okay. See, of course, suspicion of pleural infection will be based on the standard things, presence of fever, leukocytosis, and how it all started, whether it started with a pneumonia or whether it started de novo, the acute phase reactants, what they are doing. There may or may not be chest pain. It is not necessary for every pleural infection or empyema to be having chest pain. But once we decide, so it is a useful idea to give the treatment based on whether it's a community acquired infection, likely community acquired, or whether it's a hospital acquired or a nosocomial infection. So it is something similar to what we do in pneumonia. If it is more likely from community, then the choices will be again the penicillins, and that includes either amoxicillin, but I think it is better to give amoxiclavulinic acid. And if and also we have to take into account how serious the patient is. So, or injectable monotherapy or dual therapy, like I already mentioned, anaerobic coverage is now being recommended more and more. So we can give a clindamycin or something like that along with amoxiclav, that is to cover for the anaerobes. And if suppose that cannot be done, then we have other choices. Suppose a person is not able to tolerate or side effects, then cephalosporin, third generation cephalosporins can be given in this situation. If it is in Western literature, monotherapy with fluoroquinolones has been advocated, but here we do not do so because of the tuberculosis part. Hence, we stick to the others. If it is a nosocomial infection, then we have to cover more for the gram negatives and also probably for the MRSA and the staph. So then it becomes the stain. The organisms will be mostly the Pseudomonas, the Klebsiella, and the E. coli. So we have to cover anti-pseudomonal, and that may be the ESBL covering antibiotics, Piptazo or others, or even a carbapenems. Along with that, we will have to cover anaerobes with either clindamycin or metronidazole. That metronidazole can be given in the community one as well. And wherever there is a high risk, then we have to cover for staph with Vanco or Picoplanin or linezolid, as the case may be. So there we have to be a little more aggressive, and that is how the empirical treatment starts while we are sending cultures and waiting for the exact organism to come up. The duration I think we'll cover later, but this is the initial choice.
I think you have very nicely elaborated the management plan, and yes, it will be further directed by the type of organism which we get on cultures. And in case the culture doesn't come positive, your empirical therapy has to be good enough to take care of your treatment of your pleural effusion. So I think we move on to the next question. Before I take on the next question, another important thing which we should know is that the duration of therapy is usually about 3 to 4 weeks. And again, it will be decided on the basis of patient's clinical response. Sometimes, especially in nosocomial infections, we may have to extend the duration of treatment. So with that, we move on to a next question to Dr. Sushmita. Dr. Sushmita, beyond antibiotics, what medical therapies, which like fibrinolytics, saline irrigation, etc., do you employ for complicated parapneumonic effusions? and an early empyema? And what are your criteria for their use and evaluation of their effectiveness? How do you use them? Can you elaborate on that, Dr. Sushmita?
Yeah, sure. So in our practice, usually the first thing that we do is we do an ultrasound, and if it looks like a loculated effusion, we upfront do a contrast enhanced CT chest, because it's a contrast enhanced CT chest that actually gives you a much better idea of the amount of loculations. And we've all heard now there's a really nice biomarker that is going about called SUPAR, which is probably going to be available soon. It's not available yet, but that biomarker in fluid can actually tell you how loculated or bad a fluid is. At the moment, we don't have it. So contrast CT followed by we do a chest drain. And after the chest drain, 24 hours after the chest drain, we do an ultrasound and find out what the situation is. If it is stage 2 level empyema and it's multi-loculated empyema, and if it's thin with some loculations or up to stage 2, upfront we do a medical thoracoscopy. When we can't do that, or the patient is sick, we use streptokinase, and we have used streptokinase to good benefit. The idea mainly is to not use streptokinase where you find really thick strands, where you find organized collections on your upfront CT. In that, we upfront ask our colleagues to, surgical colleagues to take over. Before that, if they are not thick strands and they are still looking multiple loculated collections, not amenable to thoracoscopy, we do use upfront streptokinase, and with good benefit in a lot of our patients. Saline irrigation is something we don't do quite regularly. In some cases, after streptokinase, we have used saline irrigation, but not routinely at all.
Okay, thank you. So in your practice, you have been using more of streptokinase, which I think the Western world don't use much, but I think in India, most of us use it and we have found to have good clinical benefit. So I think it has some role, at least in Indian conditions, and we need to have our own data and publish it so that we can tell the world that yes, it still works, and most of us believe it. And there is some role of medical thoracoscopy, which is still evolving, and we still need to have a definitive answer for that also. With that, I move on to the next question to Dr. Amit Dave. Amit, how do you monitor the response to medical therapy, and what are your red flags that suggest medical management is failing?
Yes, sir. So as Anand sir and ma'am have elaborated, Anand sir is given the idea of very nicely to give an empirical antibiotic. And as we know that the culture arrives within 3-4 days, and that too only 30-40% of the patient we get a culture positive, and we guide the antibiotic therapy. So at the moment, somewhere around fourth day or fifth day, if your patient is getting pyrexia, continuous pyrexia, those are the clinical markers. Pyrexia, biochemical marker like C-reactive proteins, and on ultrasound, that if your effusion initially it was a free flow and now it is getting little bit septated. So these are the few red flag signs that medical therapy is not doing a well or not going to in vain, and you have to act on some kind of intervention, either a therapeutic thoracosynthesis or tube thoracotomy, or maybe intrapleural fibrinolytic therapy, as ma'am have discussed in previous question.
Okay, thank you, Dr. Amit. I now move on to the next question to Dr. Manjunath. Dr. Manjunath, at what point do you typically get involved in the workup of a pleural infection? Are there specific diagnostic findings that prompt early surgical consultation? How do you are normally getting consultation for, and when you usually get involved in such cases? What is your current practice? Dr. Manjunath?
Yes, sir. Yes, sir. Yes. Can you hear me, sir?
Yes, we can hear you.
Yes, sir.
Have you heard the question, or should I repeat it?
Yes, sir. I've heard about it, sir.
Yeah.
So basically, there is a very close association required between the surgeon and the pulmonologist, because most of the time in where I was working in the previous center in AIMS, we had patients who used to come very late, basically because the patients have been referred from some other centers, and they used to come with a very thick pleura, with calcified pleura and stuff like that. But I can say there is a change in the demography in my own patients since I moved to the corporate setup. We get early cases where we have patients who are still having multiloculated effusion, minimal pleural thickening or some pleural thickening. Now, when are we involved? We are involved very early when there is a multiloculated effusion, not amenable for single drainage or a ICD, or if there is a pleural thickening which is already present, then I think the role of surgeon becomes more eminent. I think the pleural thickening is one of the things which actually is a major demarcator for surgeon to be involved. And other thing is patient's condition. If it is a septic patient, then a surgeon may be involved much earlier than it was previously thought of, sir.
Okay. Thank you, Dr. Manjuna. It's really good insight from a surgeon's perspective. Now we move on to Dr. Sushmita.
Sir.
Dr. Sushmita, what are the common pitfalls or areas of miscommunication that can arise between medical and surgical teams where managing these complex cases, and how can these be avoided? Dr. Sushmita, please.
I think the answer is in your question. It's miscommunication. I think it just needs to be one, seamless team rather than me versus you. The problem is that in most hospitals you don't have a good thoracic surgery backup, and that is where what happens is the pulmonologist tries to do everything they can rather than actually assess whether going a certain distance and then having a boundary is better than going all the way and not having any choice left for the patient. So basically, to talk about our own selves, we need to have our boundaries. People, because it's more important to know what you shouldn't do rather than what you can do. And that comes in place when you know that an empyema is far gone for us to do conservative management about, or go in and put in your thoracoscope and then come out and doing nothing. It's not really going to help. So knowing your boundaries is enough. Getting thoracic surgery colleagues in early is enough. And also, the problem is that what I hear from a lot of my colleagues is that surgeons just want to operate whenever they see something. They don't really like to wait. But I think it's more about an MDT as it would be everywhere. When a patient comes to us, sit down, have a chat, that this is what the situation is, this is what we aim to do, and what do you think is your plan, and each of us know our roles better. So it's just respecting each other and respecting above all the patient's choice of least, harm that can be done, because there aren't really true guidelines as to where your role stops and the other person's role begins.
I think that's very important, that having good communication and knowing your boundaries and sharing the patient together as a team rather than individually practicing and trying to do everything. I have seen a lot of people who have been doing thoracoscopy for stage 3 empyema, stage 4 empyema, and then it doesn't work. So we have to know where to stop and where not to attempt that. I think now...
Sir, can I add one point here, sir?
Yeah, please.
Sir, actually, sometimes when there is a doubt, we have a very close coordination with our pulmonologist, and what we do is they ask us to be standby, and we stay there and see if everything is getting cleared. If there is a doubt that the medical thoracoscopy is not sufficient enough, then we counsel the patient and then do VATS on the same setting. So I think, like as Madam said, Madam was right. Sometimes surgeons can be uncooperative. But if you develop a good rapport, I think it will make life easier for everyone, especially for the patient, sir.
Yeah, I think that's correct. So your team is lucky that they have you.
No, actually, in a way, it's opposite, sir. Actually, if they are very supportive, and then we have a discussion which is totally based on the patient outcome. What matters to us is patient outcome. So that makes it easier for us to take a decision.
I think becomes a shared responsibility. I think that's great.
Exactly.
Yeah.
Exactly, sir. Yes.
Okay, I think that's really good. So now we move on to our next question with Dr. Anant Mohan, sir. Sir, can you discuss the role of a multidisciplinary team, that is including infectious disease specialists, the radiologists, etc., in optimizing the outcome of patient with pleural infections? How do you work at AIMS, and what's your take on it?
Yeah, so I think that the last question also was something related to that only.
Agreed.
That just like in lung cancer, just like in ILD, now the trend is going towards a multidisciplinary discussion, so that one is able to, in one sitting, one is able to discuss everything and find out what is the best. Similarly, here also, it is actually not just the domain of one person. And as you have seen, starting from, in fact, I would say we should involve apart from the respiratory physician, even the microbiologist. The microbiologist role is so important. It is
Yes.
often underestimated, I would say. And Dr. Richa has already said that the yield of a pleural effusion is not more than 40 to 50%. So in the best of centers, so that has to increase. Otherwise, everything will be empirical at the end of it, and we will be trying to go in more deeper into tissue. So a microbiologist, the radiologist is very important, again, because of course many things can be done by us on the bedside as a by the ultrasound. But suppose we need to do something more, suppose we decide to go for a pigtail, then a ultrasound guided pigtail will need to be inserted, or we need to decide whether pigtail will work or not work. So they may say no, it doesn't work, go for a chest tube, go for a surgery. Or if they say no, look, this is the loculi, first put it in this loculi, drain it out, and then there are others, you do something. So all these things will happen when surgeon has to be there, like already have been discussed. Hence, a multidisciplinary team, I think, is very important, and not just one. Maybe at different phases of the treatment and management, it will be required. For starting, how to for how to aspirate the patient, the effusion, whether to put in any device, pigtail, simple tube, or something more than that. Any fibrinolytics, how much is the fibrin, how much are the adhesions, etc. So a lot of things can be handled at that point of time. And then, of course, the culture and the sensitivity also is very important.
I think that's very important to involve the microbiologist, and I think we should have our local data about the what type of organisms we are growing in our hospital, and also what is the sensitivity pattern there. I think that also makes a lot of sense in decision making about the antibiotics. Thank you, Dr. Anand Mohan sir. Now the next question is to Dr. Amit Dave. Amit, what are the emerging technologies or therapies that hold promise for improving the diagnosis or treatment of pleural infections? We need to know about this from you. So, can you shed
Yes,
some light on it?
yes, sir. Yes, sir. So, as already ma'am has mentioned about SUPAR, there are few novel biomarkers are coming up. SUPAR is not yet. It is basically pleural fluid soluble urokinase plasminogen activator, which accurately predicts whether patient need invasive management compared to conventional biomarker. And it's a soluble form. So uh, if it is assessed earlier, then you need to do intervene in intrapleural fibrinolytic therapy versus thoracosurgery. It can assess, but it's still in yet research base and yet to come in India available. So another newer technique already Richa ma'am has mentioned, that risk stratification, the rapid score that she elaborated in her lecture, the rapid score, but the evaluation we have to predict on that particular that, and few other treatment that all in pipeline, that intrapleural antibiotic therapy or intrapleural irrigation, like ma'am has mentioned saline. But these novel technique of pleural irrigation or intrapleural therapies need proper address.
Thank you, Dr. Amit. I think you have nicely elaborated this. So newer therapies are still on the way, and we still need to know more about them before we incorporate them in our clinical practice.
Yes, sir.
My next question is again to Dr. Manjunath. As we all know, timing is very crucial in surgical management of pleural infections. And according to you, what is the ideal time for surgical interventions, and what are the consequences of a delayed surgery?
Sir,
Dr. Manjunath.
stage two empymas, let's say, for example, 3 to 4 weeks within the onset of pneumonia, the surgery will be very easy and the outcomes are best. The moment the pleural thickening becomes more and more, as we see, most of our patients coming from periphery have this problem where they have been managed for months with the thick pleura and loculated effusion. That obviously they'll have more issues, sir. The problem what happens is every time there is a thickened pleura, we try to remove it, there is a chance of having a risk of air leak post-operatively. So the earlier the better. Now there is always a question of tubercular empymas. How early should we treat? If it is sputum negative, should we wait for 3 weeks or 4 weeks? I think overall the practice has been that we wait at least for 3 weeks of starting ATT and then plan for a decortication.
I think we are discussing non-tubercular infections here.
Yes,
Tubercular
yes,
we'll discuss it separately.
Yes, sir. So in case of pneumonic, I think 3 to 4 weeks after the onset of pneumonia is the ideal times.
Okay.
Yes.
So if your medical management is failing, then the next step would be going ahead and doing the surgical intervention.
Yes.
Okay. Thank you, Dr. Manjunath. Another question to you. What are the common post-operative complications we encounter after surgical decortication and how do you manage them? Because we also need to know, the physician should know that what are the complications you encounter and how you manage them. That's important for us also.
Sir, one of the most common complications is post-operative fever. The post-operative fever, which can happen due to two things. One, there might be a persistent loculi which is left behind. Sometimes we see this in the interlobar fissure. You are draining the whole pleura, and you leave behind loculi within the fissure. That can act as a persistent site of nidus. The other cause can be collection in the posterior aspect of the diaphragm, where the collection can be there, which is not drained, and that can act as a nidus of infection. And other than that, you have pneumonia itself causing post-operative fever. The other complications we notice are in cases of other comorbidities like CKD, where there is chances of high bleeding. CKD and CLD both have high chances of bleeding in the intraoperative and postoperative period, needing re-exploration. And if they come in a delayed stage, you have higher risk of air leak and bronchopleural fistula. These are the main set of complications.
And how do you manage air leaks? Especially, I think this is something we usually get worried about in late empymas. So how do you manage the air leaks?
Categorizing an air leak is very important. Categorizing whether it's an alveolar pleural leak or a bronchopleural leak is a very important aspect of any air leak management. The moment you say bronchopleural fistula, that means there is some major leak which is there, which is both inspiratory and expiratory. But if it's just a alveolar pleural leak, they generally heal on their own and settle down with the negative pressure, in situ spirometry and physiotherapy, and good control of infection with appropriate antibiotics. If it's a bronchopleural leak, that means when doing decortication, a segmental or a subsegmental bronchial is opened up, which will not heal on its own. Then we might have to think for other ways of doing it, either a re-exploration or an intervention guided procedure like a glue or a spigot or something can be tried if it's a bronchopleural leak, sir.
Okay.
And other important thing is whether the lung is expanded or not expanded. If you have a bronchopleural fistula and still if the lung is expanded, then we can wait for longer with the chest tube and give time to heal. If the lung is not expanded, then you are left with very little choice with trying something, either bronchoscopically or surgically.
Okay. Thank you. Thank you, Dr. Manjunath. Now we move on to the next question to Dr. Amit Dave. Amit, are there any specific patient characteristics or comorbidities that would influence your collaborative decision-making process for intervention?
Yes, sir. All those empyema and tubercular empyema patients do have very nutritional deficit stage. Many patients do have a seropositive status. Many patients are on chronic dialysis, or many patients have a cardiac conditions. Those patients particularly need to address separately in a special situation, because these interventions itself for them are more detrimental in a collective stature. So these group of patients need to address more conservatively and more strategically than the more immunocompetent patient, I would say. So a few group of patients you can go early as diabetic, but not that much immunocompromised. Another population we called as a geriatric population, old age population has also some their own cardiovascular status. So before going more invasive therapy or more surgical therapy, need to assess their overall status before going in a intervention for the pleural condition of that particular patients.
So you have to decide case to case depending upon the patient's
Yes, sir.
comorbidities and
So-
clinical condition, how you manage them. So there are
Yes, sir.
special situations which you have to manage differently. And
Yes.
maybe with patient with multiple comorbidities, you have to be more conservative and
Yes,
you have to be more careful. Yeah, thank you.
Yes, sir.
I think with this, we move on to our next question to Dr. Anant Mohan, sir. Sir, what is the role of rehabilitation and physiotherapy in optimizing lung function and recovery after pleural infections? I think this is the area which we normally don't discuss. So I think this is an important question. Can you elaborate on it, sir?
Yes. Basically, pulmonary rehabilitation and chest expansion techniques always have a role wherever the lung is collapsed for some time, and especially in empyema, especially if it's a massive empyema and then we drain it out, we don't know whether the lung is trapped. It may be trapped, partially trapped. We have to try, and one is that we have to try and expand it. That is the one thing, to make it fully expansile. And for that, we have breathing exercises, we have various incentive spirometries, and other methods are there as part of pulmonary rehabilitation, which are to be done. So all these things have to be done, and especially this is the non operative setting. In the post operative setting, of course, we know if any thoracic surgery is done, then that has to be followed by a good aggressive pulmonary rehabilitation program subsequently, not just for airway clearance, secretion clearance, but also again for building up the muscle strength, also building up the diaphragm strength, building up the expansion of the lungs. So all of these together work for helping the lung to expand, especially after the fluid has been removed, or after a chest tube has been removed, or a surgery. And also because partially the lung might be entrapped, so that needs to be taken care of.
I think, thank you, Dr. Anant Mohan, sir. Now, the next question is for Dr. Sushmita. This is an important question. Dr. Sushmita, what are the most pressing research questions in the field of pleural infection that need to be addressed? I think there we are lacking. All Indians, we are lacking on that. And I want to know your point of view on which are the specific research questions we should address first in our setup, in our Indian settings.
Yeah, I think that's a very important question, and this is one topic which is fraught with research questions because we really don't have clear answers to straight away, starting from diagnostic parameters. As we just spoke before, that the parameters that we have for diagnosis have their own limitations, starting from culture. Culture is positive only in 36 to 40%. Can we develop better culture methods to get, better answers early? Then it comes to what should be the treatment, especially how to guide the optimal antibiotic strategy, how long to give it for, what should be the timing, and what should it be, because as you said, it has to be guided by local antibiotic, which we mostly don't have in our country. What should be the duration? How long should you give IV? And is there any scope of changing to oral as we do in pneumonia after a certain period? Those are areas that we don't really know. And in the era of antibiotic stewardship, this really comes in with a significant amount of, importance. The other thing that we have always been talking about is drainage. How to do drainage, and at what point can you use fibrinolytics versus saline irrigation versus surgery. These are areas that we really don't know about. So diagnostic parameters, then, culture, treatment, drainage, and above all, we really lack the patient's perspective, patient-centered outcomes that need to be dealt with, which we rarely look at. And especially in our country's sake, that is something we should be looking at definitely. Developing for biomarkers which I think can be done everywhere else in the world, but looking at what biomarkers might be suitable in our country's context, where tuberculosis is such an important plays such an important part in pleural infection. I think these are areas that need to be looked at.
Okay, thank you, Dr. Sushmita. There is a question from the audience. A role of MESNA in loculated pleural effusion. I don't know. I don't have any experience on it. Any of the panelists have any experience of a role of MESNA in loculated pleural effusion?
I haven't used it.
No one is using my knowledge. But the streptokinase has a good role, and already
Streptokinase, all of us are using it, but I think MESNA I have also not heard, and no one have used it. At least none of us have used it. Any experience of Anand Mohan sir?
I think MESNA is good for endobronchial thick mucus and obstructions, but not really in pleural infections.
So I don't think there is any study also. I not heard about it using in pleural space. So answer is no, we don't have any experience on that. There is another question by Dr. Mahendra Singh from Madhya Pradesh. In case of hemorrhagic pleural effusion, which is exudate, ADA is borderline lymphocytic predominant. What should I do?
I think Dr. Richa has already answered. I think maybe
Dr. Richa,
questions.
Yeah.
Can you answer this question?
No, I'm there. So I think what I was doing was, while the lovely discussion was going on, I was trying to answer all the questions, but then the technical team told me that they are not able to see that. Then what I did was I'll copy paste it into each of their replies. I'm not sure whether they have got it, but yes, if it is an hemorrhagic effusion and its cytology is negative, ADA is borderline, you certainly have to look for what is the etiology, and I think you need to do a biopsy, whether it is medical thoracoscopically if feasible, or image guided biopsy, and prior to that probably doing a CT scan would help you in deciding what you should go further. We should not leave it, or we should not consider that this could be tuberculosis.
So I think definitely we need to have a tissue. Tissue is the issue. We should always go for biopsy, either thoracoscopically or image guided. I think that's the way we should do. Now there is another question which you have already discussed. Intrapleural antibiotics. Anyone having any experience of it? I don't think we are using it. Not much of data on it.
Yeah, I think
Dr. Richa, any other question you feel that are significant? You have been answering the question, thanks to you. So any other important question?
No, most of the questions actually we have discussed with the panel, and MESNA was something which I didn't knew, and there was a role of early chest physio while I was about to write. Anand Mohan sir has already given an important answer to it, and I think we have covered all the questions.
Okay.
If they are listening to it, all the questions are answered.
Okay, so I think anything else can.
I can see all the answer of ma'am has written nicely with paragraph. So it's very good to read those answers. I hope the audience will able to see those reply.
So I think we have answered both by texting them, and as well as verbally we have discussed it here. Yes. So all the questions have been discussed. Anything else any of the panelists would like to add in this?
Sir, I had a very peculiar scenario, sir. So basically, this was a right lower lobe CA lung. We sent him for chemotherapy. Big one, because it was a big one, 9 centimeters. So we sent him for chemotherapy. He came back with a tumor rupture and an empyema.
Okay.
Now I want all the panelists to answer me this, solve this scenario. How do we go about this scenario?
So, I think Dr. Sushmita?
Yeah, empyema, drain it while you continue with the chemotherapy under antibiotic cover. Gradually, the basic idea is that the tumor itself has to gradually shrink, because as long as it is there, you will continue to have a post-obstructive infection, and you'll continue to have a problem. So there has to be a drainage route. Antibiotics at the same time, chemotherapy needs to ongo. We had about 3 patients like this, and all of them under cover of antibiotics and continuous drainage, underwent chemotherapy. Two of them actually responded better. The third one didn't. He actually died of sepsis. But these are the three things you need to do together.
Agreed, I think. But I think first we drain and cover with antibiotics, and when the infection settles a little bit, then give chemo. That would be a better way of doing it.
In such a big tumor, you really don't have time. So once sepsis sets in, you give them at least 7 days of treatment. And if they're settled, most of the chemo that they give is half dose chemo anyway, because it sounds more like a palliative chemo rather than a full dose chemo. But again, it depends on the chemotherapy team and how aggressive they are about it.
Of course, most of the chemotherapy, most of the chemotherapeutic regimens are 3 weekly.
Yeah.
So one can kind of give antibiotics in between two chemo regimens if that works. So I think that should suffice. And then of course you have options of reducing the dose as already mentioned. So
yeah, I think that's the answer for it. One interesting question is there. Does USG guided therapeutic tapping be used as treatment if minimal amount is present in empyema? So
Yes.
Dr. Nanmohan sir.
minimal means how much? I mean, if it is tappable, then yes, tap it. But minimal, if it is not tappable, then obviously we would not like to unnecessarily put in a needle and cause a further pneumothorax. So if it is easily tappable, go for it. Otherwise, just treat it with antibiotics and see again. Yeah.
Okay. I think that's the way it should be. And if it is a small amount, yes, it can. Yeah, you want to say anything, Dr. Richard?
I just wanted to add. So if they're saying that it is an empyema, so I believe that the empyema was drained and then something is remaining. I don't know.
To start with, if it is not much, for example, it is 200 ml, it is empyema. Just taking a case scenario like that.
In that case, as Sir said, if it is tappable, it should be removed.
No, my question is, should we put a drain or we should just tap?
No,
that's the question.
200 ml, you would be able to put a drain.
Okay.
So it's very difficult to put a small.
Yeah, there's a very big tendency these days to put in a drain for whatever volume. We've always been told that you can easily tap up to 500 to 800 ml at one sitting. So if it is thin and it can be tapped, the idea in empyema is to free the pleural cavity of as much fluid as possible. So if you are not really clear how much there is and there's lots, then you put in a drain. But if it's just 200, 300, 400, you can tap it at one go.
So, okay.
Agree.
Maybe a little difference in opinion. In empyema, if it is, say for example, if it is a frank pus, I would probably keep a drain there.
Yeah.
If it is a frank pus, I would, even if it is 300 ml, I would put a drain rather than just aspirating. Probably that would be my approach.
So it's depend on the person, sir. If your patient has a tubercular empyema and just...
No, we are not discussing about TB. We are not discussing about TB. Sorry.
I would also say if there is, you are able to see an effusion. See, just the blunting of the CP angle means there is around 50 to 100 ml of fluid.
100 ml.
You need not do it. But if it is pus, you would certainly, there are lots of, that Cook's aspiration needle is there. And around you can keep it for a day. It will drain out everything. But the cost is an issue. But if it is something more than that, I would rather put in a tube if it is frank pus.
Yeah. And I think important is the size of the tube, which you have not discussed.
Yes.
I think you should, now they say that even smaller size, 14 French is good enough. You don't need to put bigger sizes. As in India, I think most of us have been putting, say 24 French or so in all empymas. So we may have,
can I answer this question, sir?
Yes, please.
Sir, when we use a smaller French catheter, the problem is clogging of the catheter. Unless you have a nurse who flushes the catheter with heparin every shift, I don't think the smaller French catheter will work for more than 2-3 days, because there is a high chance of a thick mucus plug or a thick pus itself clogging it up. So, as you said, 24 French is commonly what we use because of the same reason, sir. Because we are not that good at the nursing care of the tube management is not that great. In West, they have
now I think there is a little difference in opinion on this. The thing is, normally now what literature says is even a thinner size tube is good enough. They have done a proper randomized trials have been done, and So even
So
50 is good enough, provided there's someone who flushes it regularly. I think that's
Yeah.
good.
Exactly.
That's important.
I think we have gone midway in our hospital and it really works.
Yeah.
No 24 size, no 14 size. We use a 20 size image guided drain and flush it twice a day with normal saline, and that works.
So we also use now 14 to 18. We have shifted from 24 to 40, somewhere between 14 to 18. That's what, depending upon the availability. And it works very well. We also flush it twice a day and it works wonderfully well. So I think size is important. I think you should flush it regularly and keep it content. Yeah. Anything else anyone would like to discuss?
Someone is asking, is necrotizing granuloma in endemic area is TB? This is someone from Egypt, Cairo. The same person is asking, what if biopsy necrotizing granuloma and fluid-rich in lymphocyte? I'm not getting it.
In
So
our
basically-
endemic setting, necrotizing granuloma, unless proved otherwise, is tuberculosis.
Yeah.
Yeah.
There
We
could be
always
other-
treat with antitubercular.
No, there could be other differentials as well.
Yes. So
The necrotizing granuloma is not always TB, but
Yeah.
having said that, in endemic area in our country, we will think that test was, unless patient is having some clinical features or radiological features which are not fitting into typical TB.
So basically do a culture as well as gene expert. I think that's important. Histopathology, culture and gene expert. This will give you an answer. Usually it is TB in our setting, but then if you are thinking about other differentials, you do all this thing. Anyway, we do it in case of a necrotizing granuloma. So I think that should be the answer.
One more last one. I think we are almost okay. 21 हो गया है. What is anyone's experience in draining or tapping a collection at apical part only?
Okay.
So not
So that
for particular,
apical local will have to be image guided. They will have to be image guided, maybe pigtail or something, Apical collections are unlikely to be very large. They may be loculated. So depending upon the internal consistency of the fluid, we will have to liaise with the radiologist and put a proper sized tube, either a catheter, pigtail or a chest tube, whatever.
I think correct that we would take the help of the interventional radiologist maybe if we are not experienced in that, and then put a drain there if it is an apical collection. So that maybe
those small collection ultrasound guided usually can be accessible.
Okay.
If you are well versed with the ultrasound, it could be accessible very nicely. And
depending upon the experience of the
Yes.
pulmonologist, if you are not very confident, and because apical collections are not so common, so having an experience of it is not so I can
Yes,
not that much. So if you are not confident, better take a help of an interventional radiologist. They will be able to help you. I think there's nothing wrong in taking help of anyone. If you think that
Yes,
you are not the best person, you can always take a help of someone. I think that will depend upon the experience of the pulmonologist who is doing the procedure.
Amit, the question came from Baroda only.
So
Okay, I think we have finished all the questions. Any more questions?
No, I think we are done with, yeah.
Acha, now there is another question from Simoga. Fluoroscopy versus rigid considering economics. What's the take? Rigid versus semi-rigid. I think both of them are good. Both of them are good. Again, depending upon your availability and your experience, you can use either of them if you are doing for a medical thoracoscopy. Cost-wise, rigid is a little less costly and more sturdy. But again, both are equally effective as far as the diagnostics or role is concerned for medical thoracoscopy. So effectiveness-wise, both of them are good. I think.
Except in terms of therapeutics, where it is too thickened pleura, loculations and adhesions, where rigid may have a score over it, but I defy with
Again, these cases are usually for surgeons.
with that completely.
These cases are usually for surgeons, so I think.
So otherwise, also, sir, I don't feel that semi-rigid by any ways is lesser in comparison to rigid.
Yeah.
No, I am just saying that cost point of view, wear and tear in medical thoracoscopy is too high as compared to rigid. So if you are doing a private practice and you are doing bits well versed with rigid, the rigid is more comfortable in terms of cost,
And
maintenance
it
cost.
is more durable. That's again important.
Yes,
Actually, that
yes,
person who has asked the question is they have asked that in concern about the economics. I think if you want to get, I think, and the cost is a concern, a rigid is good enough to do everything, but you need to be trained on it. And it's
yes,
equally or
yes,
maybe
sir.
sometimes better, especially in thick and pleura, a lot of adhesions. It may be a little better in that. But otherwise, both result wise, both of them are good. I think
Yes.
so. Okay. I think we finished here. Anything else?
Sir, I want to add one last point, sir.
Hmm?
Sir, I want to add one last point.
One second, Manju. Anand sir has to go.
Yes, sir.
Thank you so much, sir, for being part of this esteemed panelist, panel.
Thank you, sir.
Thank you.
Thank you.
Thank you
Thank you,
so much.
sir. Thank you,
Thank you.
sir.
Thank you. Thank you very
Bye
much.
bye,
And
sir.
We can
so
continue.
there is another question.
Manju, you were saying
Surgeon,
something.
Okay.
yeah, most of the time, a surgeon is considered to be a 12th man, but sometimes he can be an impact factor also. So I think that point I would like to emphasize again to all our pulmonologists.
Mhm.
That was a sore point you put through.
I think
No, as ma'am already said that we are trying to multidisciplinary and we do up to stage 2. Stage 3 and stage 4 we are referring to surgeon. See, we are not well versed with those decortication. And we need your help, Manjunath.
And
It's nothing like that.
as you said, Manju, your tribe needs to grow. You know, most of the hospitals don't have the luxury of a thoracic surgeon. We are
yes.
very lucky that we have a thoracic surgeon. He's a friendly one. He's around. If if it's not our case, we can straight away refer. The patient doesn't have to run here or there. So your tribe
Yes,
needs to grow. And then that way, I think together we can make a lot of difference in an empyema patient's life.
True. True.
Yes,
sure, ma'am,
true.
sure.
I think we have finished, covered most of the questions. And should I now wind up this webinar? Dr.
I
Richa,
think I just
Manju.
take a 30-second to congratulate you and Richa ma'am that I can see the reach up to Mauritius, Bangladesh,
Pakistan.
Egypt, and Pakistan also. There is a one question ma'am has
I have
answered.
tried to make it
So-
global.
So
We tried to make it
you are
global.
on global, sir. That you must have to register this and publish under banner, sir.
Okay.
Kudos to your vision.
Thank you. And I think it's all a teamwork, and we are now working hard to make pleural diseases a very important part, and we are trying to get it recognized among pulmonologists. All of us were doing a lot of work on pleura, but we don't publish. That's a weakness, and we need to improve on that. And we are trying to learn from each other. I think we summarize our today's webinar in a few words. First thing is early diagnosis, picking up the patient at the early stage. That's important. Then starting the appropriate antibiotics. That's the second important thing we need to remember. Draining it on time and depending upon the pH. Again, pH very important. A lot of people in India don't do it. Start doing it. It's very easily accessible and available in your hospital. Yes, you have to pursue and get your lab do it for you, and that's very important. Doing pH, LDH, and glucose in individual case scenario wherever is needed can help you to decide whether you need to drain or not to drain. And after drainage, if think that there is a collection, then you may consider for intrapleural therapy or medical thoracoscopy. Again, depending if it is an early empyema. If it is a late empyema, then maybe that's the case where you may have to involve the surgeon. I think that's a broad coverage of today's webinar. There are a lot of gray areas where there may be opinion differences. Sorry for that, and we will try to fill the gaps in next couple of years. We'll try to do our own studies and publish it. That's the wish and promise to all of us, and what we all want to do. And I think I end the webinar here. Any comment from our expert panelist and Dr. Richa? Final words from you and Dr. Shushmita, Dr. Manjuna, Dr. Amit?
No, sir. I think we're just trying to fill the gap which was there in the country, and I believe
Globally.
we do so globally. Okay, we continue to do so.
Okay. So there are a lot of gaps there, and unfortunately, as I said, BTS guideline, which is the latest one, don't touch about medical thoracoscopy. They outright reject streptokinase, so we need to work on that. So we have to
Yes, sir.
really find the solutions for and get the answers for these questions. And we hope that we have done justice to this topic today. And I think we close here now.
So we
Thanks
have
to all the
final remarks.
panelists.
So we
Thanks.
have sorry, sir. Sorry. We have final remarks from the panelists as well.
Yeah, please.
Between, sorry.
Yeah,
Yeah.
please.
I
Dr.
think
Amit, please.
Yes, sir. I just do agree with your vision that we need to publish more data, and we may have a little bit difference of opinion among other, but we have to come on the same side of the table and publish a robust our Indian experience and put on the globally that yes, we are using this thing, and yes, it is possible. The most important, as we discussed in starting, that still I believe streptokinase is still helpful in many patients, and DNase alpha and that TPA is too costly as compared to streptokinase, and many patients do help. So you are rightly said, sir, that we need to put our foot forward globally to show them that yes,
And
this
it's
is
not just the cost, availability is also a problem. So even if there
Yes,
is a
sir.
patient who can afford it, we are not able to access it. So that's another
Yes.
issue. And
So,
definitely
accessibility and affordability in
both.
our part of country is more important.
And it's
treating
in
the
across Asia. I
patient.
think many countries in Asia it's not accessible. That's what I know.
Yes, yes, sir. Yes, sir.
Uh,
Sushmita, ma'am.
Sushmita, madam, Dr.
Nahi,
Sushmita, please.
yeah, I think this is an excellent platform, and we've been, it's a good opportunity for all of us to get together and get a really neglected part of pulmonology to be streamlined, to be, brought into simplification so that people know the diagnostic strategies, the management strategies, and also these areas where countries like ours, where fibrinolytics can actually help reduce the load of surgery in a number of patients. To bring who are the right people, when to do it, and also to recognize the ones that should be straight away sent for surgery and not dilly-dallied upon. It's a good opportunity all of us have. So
Yeah.
bring data together, bring the evidence, and publish it.
Yeah. Dr. Manjunath, you want to say something?
Manjunath, sir, you have to unmute yourself.
Unmute, please. Dr. Manjunath, I think he is.
Yes, sir. Yeah. Sir, my last point will be surgery now for stage 2 empyema especially is a very straightforward one, and we don't even need them to place in the ICU for even a single day after a stage 2 empyema surgery.
Yeah.
So I think this is the message I want to convey, because when we think of thoracic surgeon, I think it's like, okay, there is always a thing that okay, there can be a lot of complications, but in a stage 2 empyema we rarely see any complications. So if that is in the back of our mind, I think the decision making becomes much easier in terms of whether to go for a surgery or not, and counseling the patient in that way becomes easier.
Okay. Thank you, Dr. Manjunath.
Yes.
Dr. Richa.
Your closing remarks, sir.
You are close.
And again, thanks to all the panelists and Dr. Richa to be here together, and we have tried to answer most of the questions on pleural infections. Thanks to all the audience who have been there with us and asking so many questions, which we tried to answer as much as we can. And I thank to the IT team and CIPLA for helping us to do the webinar today. With this, I close the webinar, and we'll see you soon in our next month Pleural MDD. National Pleural MDD will be having next month. We'll announce the date soon. And we are doing alternate month, we are doing National Pleural MDD, and an alternate month we are doing a topic on pleural diseases. That's the way we are functioning in our webinars. And with this, I close today's webinar. Thank you. Thanks, everyone.